Hey there, Paul Logan here. Today we're going to talk about hemodynamic monitoring. So let's talk first about why we do it. Well, we do it for a variety of reasons, but really it's just so we get a really comprehensive assessment of everything that's going on with somebody hemodynamically. So that can include assessing blood flow, tissue perfusion, how well oxygen is being delivered, fluid volumes in different spaces, most especially the intravascular space, and then trends over time as well. And by the way, I have the picture of the woman here with the helmet on because this is going to be a really in-depth lecture. You might want to get a helmet for yourself too, just to protect yourself. Want to protect your brain. So who requires invasive hemodynamic monitoring? Well, certainly unstable, critically ill patients, patients in shock. Even though most of our patients who have cardiac surgery are what we would consider to be routine and not terribly ill, it's still very important that we monitor them carefully. And hemodynamic monitoring is a big part of that. And then finally, patients with heart failure and end-stage heart failure, we often have hemodynamic monitoring in place for them as well. So refresh your memory about cardiac circulation. There's one thing that I want to point out to you that you probably haven't considered before, but maybe you have. The oxygen content of blood coming back to the heart differs depending on the tissue that it's coming from. So as the blood comes back from the head, it has X amount of oxygen. And when it comes back from the lower extremities, it has a different amount of oxygen content. They mix together here in the right atrium and then in the right ventricle and in the pulmonary artery. And that's an important thing to understand. The oxygen content is different depending on what part of the body the oxygen or the blood is returning from. So keep that in mind. So after the blood goes to the pulmonary artery, it goes then to the pulmonary capillaries, and the capillaries then are up against the alveoli, and that alveolar unit that we've talked about is responsible for the gas exchange. Gas exchange happens. The blood then goes to the pulmonary veins and goes back to the left heart. Higher pressures on the left side, remember, and then the blood goes into the left atrium, through the mitral valve, into the left ventricle, and then out through the aortic valve and to the rest of the body. All right. So that's that. Now I'm going to talk to you about something that you may not have picked up the first 10 times that you heard it. If you're anything like I was, I didn't get this stuff until I really started working in a cardiac surgery ICU. It takes a long time to learn some of these concepts. Now let's start with preload. So when you think preload, I want you to think about the stretch on the fibers of the left ventricle. Okay. We usually talk about left ventricular preload. So let's just think about the left ventricle here. When the ventricle is very full, it's stretching the fibers of the left ventricle. And when we stretch them to a certain point, we get really good stroke volume. The stroke volume being the amount of blood ejected from the heart with each heartbeat, right? So the more we stretch the fibers, as defined by the left ventricular end diastolic volume, the more we stretch those fibers, the greater the stroke volume will be. Until we get to a certain point where we stretch the fibers so much that they can't really function as well and the stroke volume falls off. That's the Frank-Starling curve. If you want a better explanation than that, you can watch this Khan Academy video. Just click on the link on your slide deck and you'll see a really good, albeit pretty in-depth assessment or under an explanation of the Frank-Starling curve and preload. Now, the other way you can think about this is to think about standing with your arm straight out and you're holding something heavy, like a book or something. If your arm is straight at 180 degrees and you have a really heavy book in your arm, you might have a lot of trouble bending that arm at the elbow in order to lift the book up. Well, why is that? It's because of the amount of stretch on the bicep. When your arm is fully extended, the bicep is fully stretched out, and you can't lift really heavy weights. But if you bend your elbow even just a little, then you can lift a much greater weight. And that's because of this same kind of relationship. Now, it's not stroke volume and end diastolic volume, obviously, but when you have if your muscle's fully stretched out, it's not going to work as well as if it's a little bit shortened as it would be back here on the curve. Does that make sense? All right. So let's move on then. When we talk about preload, we don't just talk about one curve, but in fact, the heart muscle, as it changes function and goes to heart failure, has a flattening of this curve, right? So in a normal, young, healthy, hyperdynamic heart, this is what the Starling curve may look like. But as the heart disease worsens, we have a much different relationship between stroke volume and end diastolic volume. Okay? So the further we go from these hyperdynamic states up here to, a normal state to the beginning of heart failure and worsening heart failure, there's a very different relationship. So that as the end diastolic volume increases, even substantially, there is not much of a difference in the stroke volume. You see that? Whereas up here, we have a very big difference in the stroke volume with even a small change in the end diastolic volume. This is the healthy heart. Okay? So, reviewing, preload is the stretch on the myocardial fibers before systole, right, at end diastole. It essentially is volume status. When we talk about preload, we're talking about volume status. That's what's affected by it. And we talk about the end diastolic pressure, because that's what we can measure. It's hard to measure the volume, right? But pressure is close enough, and we're going to use that as our metric. Next is afterload. So afterload is the pressure that the heart has to overcome to eject blood, right? And you think about, what is the pressure if you're standing in the ventricle and you look up at the aortic valve and you're waiting for that valve to open? What pressure does the heart have to overcome to open that valve? Well, it has to open up, it has to overcome the diastolic blood pressure, doesn't it? Right? You think about that. The first pressure that's going to go and open up that valve is when it gets to the diastolic pressure, not the systolic pressure, but the diastolic pressure. Okay? If you want more of an explanation about that, click on this link. Again, a very good explanation from the Khan Academy people. So remember, afterload is the force needed to eject blood out of the ventricle, and essentially it's the diastolic blood pressure. You can just think of the diastolic blood pressure as being afterload. Okay? Then there's this thing called cardiac output. Well, cardiac output, I think you probably remember, is stroke volume times heart rate, right? Well, that's really what you need to know, but there is more to it than that, and we're going to talk about what else is involved in that. It involves the heart rate, yes, but it also involves preload. The preload helps determine the stroke volume, as we talked about. Then there's the contractility, or the force of contraction, that has to do with the stroke volume. And then finally, afterload has a big role to play as well. And we're going to talk about all these things in more detail as we go. So that's all well and good, but what does the stroke volume, the systemic vascular resistance, and all those other numbers I hear about, what do they mean? Well, here's the answer. So the stroke volume, as we talked about, is the amount of blood pumped by the left ventricle with each heartbeat. We talked about the cardiac output being the amount of blood delivered to the body, and that's expressed in liters per minute. Then there's this thing called the systemic vascular resistance. So if you remember any of your physics courses, then you'll recall that resistance is something that we have to take into account in any system, in any fluid system like this, or with electricity, for instance. And we express that in this really weird way called dyne seconds per centimeter to the fifth. It's very weird, but just assume that that we're using those units when we talk about systemic vascular resistance. And then there's also the pulmonary vascular resistance, which is expressed the same way, but that's for the resistance of flow through the pulmonary circulation. All right. So where do we get all these numbers from? Well, we get them from this thing called a pulmonary artery catheter. This was invented by I should say the Swan-Ganz catheter, which is one type of pulmonary artery catheter, was invented by two cardiologists at UCLA in the late 60s, early 70s, named Jeremy Swan and I can't remember Gantz's first name. Sorry. You probably don't care, but that's okay. So this pulmonary artery catheter is kind of a cool thing. And there's actually a video on YouTube that has a little interview. It's a 1-minute interview with Dr. Swan, and he was talking about his inspiration for developing this, because up until then, pulmonary artery catheters were just long catheters that they put in through the groin and they went into the heart, and then they just kind of had to direct them around, and it was hard to do. And after taking care of this really sick patient one night, and not very successfully, as he mentions, he then went to the beach with his kids the next day, and he was sitting on the beach and watching a sailboat out on the ocean. And he determined at that time that that's exactly what he was missing, was some sail or some way for the flow to actually take the catheter where it was to go. And so what he did was he and Dr. Ganz got together and invented this flow-directed balloon-tipped catheter that could be delivered to the downstream flow of the heart. So that's what he did. And so they invented this catheter, and today it has been improved upon substantially. And, I shouldn't say substantially. It was pretty well done when they came up with it. But it has a balloon that inflates here with this little syringe that's attached to it. And so the red port is always the balloon port. And then there's a thermistor here. This is an electronic, it's just a wire that goes down the length so that we can measure the temperature at the beginning and the end of this little circuit that it does. And then we have a couple of ports that we can hook up and infuse drugs through or monitor pressures through. And that's all there is to the pulmonary artery catheter, or the Swan-Ganz catheter. So there is a little video here for you. This guy goes through and explains all those things in more detail. Feel free to click here if you're interested in watching that. I'll let you do that on your own. So how do we get these things in? Well, first we have to put a introducer sheath into some vein. So it can be in the internal jugular vein, which is where we typically do it for heart surgery. It can be in a subclavian vein, or we can do it in the femoral vein in the leg. And the way we do this is we put this catheter, or this sheath, in. It has this blue dilator on it. See that dilator? That actually comes out after we get the catheter into the groin or wherever. And then what's left is this sheath here through which we can draw blood or insert a catheter. So right here where this blue dilator goes, we can then put a Swan-Ganz catheter through there. And then there's this this other port through which we can deliver medicine. So there is another video here for you to watch that shows you how the pulmonary artery is catheterized. And so after we get that introducer sheath in place. We put the catheter in, and this shows how that's done. Feel free to watch that. Again, all you have to do is click down here on your slide deck. So once the swan goes in, we can see it on x-ray. So this is a internal jugular approach. And so the catheter goes in here. You can see the end of the introducer sheath down here. And then through the introducer sheath goes the swan, or the pulmonary artery catheter. And it can go one of two directions when it gets to the bifurcation in the pulmonary artery. It can either go to the left side, which it doesn't usually do, but I've seen it, I would say probably 20% of the time it goes to the left. Usually, though, it curls kind of like it comes in the package, just in a big circle, and it goes into the right pulmonary artery. So what do we do with the pulmonary artery catheter? Well, one of the things we can do is we can measure the cardiac output. And this actually is, I copied and pasted this from Swan and Gantz's original paper I think it was in JAMA in 1971 or so, where this was the new method, this thermodilution method that they developed for determining cardiac output. Until then, they had injected green dye in. Cardiologists used this green dye to inject into the ventricle, and then they would see what it looked like in the pulmonary artery using some other technique that I don't understand. So the whole idea here is that we have a temperature monitor up here, and we know the temperature of the injectate, or the liquid that's being injected. Back when I started, we actually had iced saline that we would use, but now the technology's gotten better where they can determine the difference much easier with a more ambient temperature than ice water. And so they inject this known temperature substance into the proximal port, which is in the right atrium or somewhere in the central venous circulation. And then it mixes with the blood there. And by the time it gets out to the distal part of the catheter, where the temperature is again measured, then we can see how that cardiac output has allowed the temperature to change. Does that make sense? So again, we inject this injectate through here at a known temperature. It comes out in the right atrium. It mixes with the blood here, changes the temperature of this blood so that by the time it gets up here, we can know something about the cardiac output. So when you inject it, we have this system hooked up, and I'll explain this to you in greater detail, but you get one of several different curves that look like either this, hopefully, or it can look like this if you have a really high cardiac output, or a really low cardiac output, it's sort of flattened and prolonged, or if you just didn't do a good job with the injector, then it kind of looks dumpy like this. So we're looking for a nice normal standard cardiac output curve, but this curve is only useful because that's the math that's shown here, right? So then we measure the area under the curve, and that gives us the cardiac output. But the computer does it all for us, so you don't have to know any calculus. Thank goodness. Now, if we don't have a pulmonary artery catheter, then there's other ways that we can determine the cardiac output. There are these other devices that are either like the Vigileo, for instance, works off of the arterial line to figure out cardiac output, or you have these other continuous cardiac output devices as well. There is such a thing as a non-invasive cardiac output device. I have zero experience with that, but I do have other experience with other non-invasive devices, and I've been underwhelmed by their accuracy. So again, I don't have any experience with this one, but if it's based on my experience with others, I'm underwhelmed. So let's talk about how do we take care of the pulmonary artery catheter, and how do we take care of the patient who has it in? Well, the first thing we have to do is realize that The nurse really is responsible for getting good measurements here. And it all starts with having everything zeroed. So we're going to start at 0. Well, what does that mean? Well, first of all, we're going to find this thing called the phlebostatic axis. And that's where we assume the right atrium is. All right. It's pretty much the same in all humans, right? So the fourth intercostal space at the mid-clavicular line, the mid-axillary line, that is the point where we would expect to find the right atrium. So we're going to put the transducers at that level because that's where the end of the catheter is, right? It's not that we want to have the catheter, or it's not that we want to set the transducers at the phlebostatic axis just because that's a cool word to say. We want to put it there because that's where the tip of the catheter is. Okay? That we're going to need that knowledge when we get to talk about the art lines because it's a little different for art lines, right? Anyway, we put the transducers here. This transducer is at that level. Okay. It can either be on the pole over here and then you use a level to get it at the right place. Or if you're in a busy ICU, usually you just put the transducer right there, right on the patient's chest, on the side of their chest, because that's where it needs to be. Think about this. If the transducer is on the floor, then you have this column of blood or fluid that's pressing down and pushing on the transducer, this pressure transducer, and that's going to artificially increase the pressure that you're measuring, right? Whereas if you hold the transducer above the phlebostatic axis, then you're going to have a harder time for that blood to squirt up and get to the transducer, and it's going to artificially lower the blood pressure, right? So that's why we have to make sure that it's at the phlebostatic axis. All right. So then the other thing that we need is to put this saline or whatever the injectate is into this pressure infuser. All right. And that means that the pressure is going to be higher than the blood pressure. Because if we have this catheter in the right heart, the pressure is probably 25 or something like that. Well, we need to have this on a pressure bag so that it's going to be greater than the blood pressure is. And that's how we have that set up. Okay. Once we do that, then we zero the monitor. And we do this in accordance with the policy and procedure of your institution. You'll probably be sick of me saying that by the end of this course, but that is the rule. And then we open up the transducer to the air, right? So that we can say that the pressure is zeroed. All right. Then we zero the monitor, and then we put the transducer stopcock back. This is the stopcock, by the way. And then we put the transducer stopcock back off to the air so that the pressure coming from the patient to the transducer is what's measured at the transducer. Okay. So again, the way we zero it is we take the stopcock and we turn it off to the patient. And then that leaves this pressure open to the air, and the transducer then is set to 0 on the monitor, and then we turn the stopcock back to off to air, and then the patient's blood pressure is what's recorded on the transducer. Okay, this is one of those things that's hard to understand on a video, I'm sure, but when you get into your clinical scenarios with patients with art lines and swans, it'll be much clearer. So we're going to back up a step here, and we're going to talk about what happens when the catheter goes in. This is where you need your helmet. So put your helmet on so you can pay attention and not get hurt. All right. This is a little heady. So when the catheter goes in, the first place that we measure the pressure is in the right atrium or somewhere in the central venous circulation, right? And when the catheter is in the right atrium or anywhere in the right vena cava, then we're going to see these things that are transmitted from the right atrium. We're going to see an A wave, maybe a C wave, and a V wave. All right. So A and V waves are things that we see. I'm sorry, I keep hitting that. A and V waves are things that we see in the atrium. All right. And since the catheter is on the right side, we're looking at the right atrium. And that's how we know that we're in the right atrium. So we see a pressure of 0 to 8. We see A waves and V waves if they're in sinus rhythm. And then we know that the catheter is in the right atrium. Then we inflate the balloon and it goes into the right ventricle. And here in the ventricle, the pressure is higher, right? It's say 25, 22, something like that. And the diastolic gets down to almost 0, maybe down to, somewhere between 0 and 8. And then the next cardiac cycle, it goes up again, right? That's with the catheter in the right ventricle. Now the catheter goes into the pulmonary artery, and the systolic pressure is about the same as it was in the right ventricle, right? If there's no gradient there, if there's no pulmonic stenosis, then the pressure should be the same. And the diastolic pressure is different though, because the pulmonic valve closes and that leaves the pressure higher in diastole. And it turns out that pressure is somewhere in the neighborhood of 10 or so in normal people. Now, if we keep this balloon inflated and let it go all the way out until it wedges in the pulmonary circulation, now the only pressure that's being seen at the tip of that catheter is this pressure. Look at this. There's an A wave and a V wave. But we're way far away from the right atrium now. In fact, that balloon is occluding the flow back here, so we can't even see what's going on there. So what do you think the pulmonary capillary wedge pressure really is? Well, it's really looking all the way through the pulmonary vasculature and seeing the left atrial pressures. That's what it is. So the pulmonary capillary wedge pressure is really the left atrial pressure. And that's a really cool thing if you think about it, but it gets even better than that. So notice that the pressures in the pulmonary artery in diastole are about 10. That's about the same as the normal pulmonary capillary wedge pressure. Well, the pulmonary capillary wedge pressure is equal to the left atrial pressure. See that? 10. And check this out. The left atrial pressure is about the same as the left ventricular end diastolic pressure. And that is what we really care about, right? Remember when we talked about preload? That's how we get the preload. We put a swan in, we look at the pulmonary capillary wedge pressure, and we can see what the pressure is in the left ventricle at the end of diastole. That's really cool. That is very useful information because that tells us about a patient's volume status like nothing else can. Really good stuff. So always remember that the pulmonary artery diastolic pressure is about the same as the wedge pressure, which is about the same as the left atrial pressure, which is about the same as the left ventricular end diastolic pressure. You did it. You can take your helmet off now because that's the really hard part to understand. But once you understand that, you'll be golden because now you know that you don't even need to wedge the balloon anymore. Now you know that as long as I have the tracing in the pulmonary artery and there's no severe, there's no major reason that number should not be believable, such as severe mitral regurgitation, for instance, or mitral stenosis, then we can believe that the pulmonary artery diastolic pressure is 10. All right, as long as there's nothing wrong with the mitral valve. Cool, right? I love that so much. So we can also get all sorts of other information from the pulmonary artery catheter. We don't measure anything else, but we can calculate things like the SVR. So the systemic vascular resistance is 80 times the mean arterial pressure minus the CVP divided by the cardiac output, and that gives you a really weird thing that we won't bother with. And by weird thing, I mean that weird dyne second per centimeters to the fifth thing. The next thing that we can get is the pulmonary vascular resistance. So remember, this is on the left side of the heart, and the pulmonary vascular resistance is on the right side of the heart. Okay. Darn it. And then there's the cardiac index. So I am 6'1" and rather sizable, right? And my 9-year-old is, I don't know, 70 pounds. Not very tall. A cardiac output for him is dramatically different than the cardiac output for me. So how can we compare our hemodynamics? Well, the way we do it is with this thing called the cardiac index. So the cardiac index is corrected for body size because we take the cardiac output that we measure and divide it by body surface area. So I may have a cardiac output of, I don't know, say 5 liters per minute. He probably only has a cardiac output of, I don't know, 2 liters per minute, but our cardiac index should be about the same, right? We both have normal hearts. Hope so. So our cardiac index should be the same. So whenever we're talking about hemodynamics, we really want to know the cardiac index. It tells us far more information than the cardiac output does because the cardiac index is adjusted for body size. Okay. There's this thing called the left ventricular stroke work index. That's a very complicated thing that I don't want to bore you with, but I will tell you that it is essentially the same as the stroke volume. So when we get the LVSWI, the reason we look at that is because that tells us essentially what the stroke volume is, or what is the amount of blood ejected with each cardiac cycle. That can be useful, right? Then there's these things down here like the oxygen delivery and the oxygen uptake, and we're going to skip that for right now. I want you to know that there are normal values for all this stuff. Remember that the cardiac output varies tremendously from, among people of different body sizes, 4 to 8. But remember, the cardiac index is always in the neighborhood of 3, all right? SVR is 800 to 1200. Dyne seconds per centimeter to the -5th. But that number is, by the way, I think I wrote this wrong. It should be Dyne centimeters to the -5th or Dyne seconds per centimeter to the 5th, right? Because the -5th indicates it's the denominator in the fraction. So I'm sorry I wrote those wrong. Notice that there's this other cool thing that we can do. Just like we can take the cardiac index, which is adjusted for body size, meters squared, we can do the same thing with the SVR. So the SVRI, or the SVR index, is also adjusted. We don't care about that one as much as we do the cardiac index, but it's still a useful thing to do because we want to adjust it for body size. Okay? But that's not it. There's even more. So check this out. We talked about one way of determining the cardiac output, but it's not the best way. There is a better way to determine the cardiac output. But in order to do that, I have to tell you a story. So I went and I drew these little pictures of a train, and the train is filled with marbles. And I thought, I'm a terrible artist. And I found this online. This critical care surgeon, physician guy in Orlando came up with this great little story that explains everything perfectly. So I'm going to tell most of the story. I'm going to skip a couple of slides, but there was a pea monster, and this pea-eating monster lived near a pea factory, and a train delivered the peas to the monster all day and all night. And as long as the villagers delivered enough peas to the monster, he was happy and he didn't terrorize anybody. So the normal pea delivery consisted of 5 train trips between the pea factory and the monster every minute. Each train consisted of 5 cars, with each car holding 40 peas. So in 5 trips per minute with 5 cars per train, 40 peas per car, 200 peas per train, 1,000 peas per minute. All right. So the normal pee consumption of a normal Happy Monster was 10 pees from each car as it passed. So he consumed 10 pees per car, 50 pees per train, 5 trains per minute, 250 pees per minute, which came out to, you see what it came out to, 250 pees per minute that were consumed. But that meant that there were peas that got returned as well. So there were 150 peas per train that were returned, and he ate 50 peas per train. That makes sense? So what does that mean? Well, it doesn't mean anything as long as everybody was happy and everything was working fine. But there could be problems. So if the pea monster got hungry and ate more peas, then fewer peas would be returned, and the factory might not be able to fully load the train cars before the train leaves the factory again, right? And as a result, there will be fewer peas to deliver to the monster during the next trip. The other potential problem is that the monster has short arms that limit how many peas he can reach. So as long as the thing is filled up, he can get the first 10 peas very easily. But the second 10 peas, he has to struggle a little bit to get to. And his arms are so short that for the next 20 peas, he just can't reach them, right? So that's a potential problem. Well, there's all sorts of other problems too. The monster could be overly hungry, or maybe there are too few cars, or maybe the train is too slow and therefore it doesn't deliver the right number of peas, or the cars are not full of peas because of some problem of production or whatever, or there's too few peas, or the wrong peas, or the peas are there are peas missing in the cars, or the train loader of peas is broken and not working. Well, you can probably imagine that all of these things that we're talking about are parts of the cardiac output. So the hungry monster refers to increased consumption. So you can think of things that would increase myocardial oxygen consumption or systemic oxygen consumption, and that could be fever and tachycardia and all that other stuff. Too few cars. Well, the cars that are carrying the peas are oxygen, right? But the thing that's carrying those peas is the hemoglobin molecule. So if the hemoglobin's low, then there's too few cars. If the cardiac output is low, then the train's too slow. If the oxygen saturation is low, then the cars are not full of peas. If there are too few peas, then the FiO2 is low. If the wrong peas are in there, then that's carboxyhemoglobin, right? Which is carbon monoxide poisoning. Make sure carboxyhemoglobin elevated. And then there can be a ventilation perfusion mismatch, which would be peas missing in the cars, or a shunt that can be responsible or that we can describe as the train missing the loader. So I hope that's helpful to you in thinking about how the cardiac output works, because it was the same kind of story that was thought about by the guy who invented the other way of determining the cardiac output. So to talk about that thing called the Fick method, Dr. Fick's method for figuring out the cardiac output, we have to first talk about the P's, right? Well, the P's are oxygen. And remember that the body has two ways of carrying oxygen. One is it can be dissolved in solution in the blood, and that we measure as the PaO2, or the partial pressure of oxygen in the arteries. That's the little a. The other way that the body carries oxygen is when it's attached to the hemoglobin molecule. And remember, a hemoglobin molecule, normal hemoglobin molecule, can carry 4 oxygens, and we measure that with the pulse ox, right? The saturation of oxygen is the amount of oxygen that's attached to the hemoglobin molecule. So Dr. Fick came up with this very fancy way of calculating the cardiac output. It's a little involved, but essentially flow, that is cardiac output, so Q dot is flow, is equal to the VO2, that is the oxygen consumption of the body, divided by the oxygen content of arterial blood minus the oxygen content of venous blood times 10. All right. Now, to make it more complicated, I have to tell you that the oxygen consumption, the VO2, is the body surface area times 1.25. Fun, right? But the CaO2, that is the oxygen content of the arterial blood, is the hemoglobin times 13.4 times O2 sat in the artery divided by 100, plus the quantity PaO2 times 0.031. That's so complicated because we have to take into account the saturation and the PaO2, right? Then we have to do the same thing in the venous blood, calculate all that. This, by the way, this is a mistake I just noticed. Sorry. It should be O2V sat, not A sat. O2V sat, because it's in the vein. And this is just way too much work, right? So let's skip it. Let's simplify this a little bit. Well, we don't need to do all that math, right? Let's simplify it and let's figure out how we can do the least amount of math and still get the numbers that are useful. Well, it turns out that the partial pressure of oxygen in the artery and the vein doesn't matter as much as the sats do. So we can get rid of all that other jazz and we can just do the SaO2, that is the arterial saturation of oxygen, minus the mixed venous O2 as the denominator against the BSA times 1.25 in the top part, all right, in the numerator. And that just happens to work out pretty well. Now, that's even too much work, though. We can actually make it even simpler. So we do this calculation, once a shift, maybe twice a shift if we need to, because it gives us, perfect information or near perfect information. We really like this. But what about this is really the only thing that's ever going to change. Is the body surface area going to change? No. Is the constant 1.25 going to change? No. Is the SaO2 even going to change? No. I mean, the patient's on 100% FiO2 or 60% FiO2 or whatever. It's going to stay the same pretty much. What's going to change is the mixed venous O2. And it changes based on the amount of oxygen that gets pulled off, right? The number of P's that the monster pulls off the train. So we can cheat. And we can ignore all this other stuff and we can just get right down to the basics and monitor the mixed venous O2. And we know that that's a decent estimate of cardiac output. So what happens is when the body delivers blood to the tissues, if the cardiac output is really low, then the blood is at the tissue level for a longer time and it can pull off more oxygen. So when the blood gets back to the heart, if the cardiac output is low, the oxygen content in the pulmonary artery is much lower, right? Contrast that with really high cardiac output, like we might see in septic shock or anemia or some other thing where the cardiac output is really high. Well, in that case, the oxygen gets sent to the tissues through the blood, but the blood is moving very quickly and the tissues don't have a lot of time to extract that oxygen. So when the oxygen or when that blood molecule gets back to the blood cell gets back to the pulmonary artery and is about to go to the lung to get reoxygenated, the oxygen level's higher. So remember that when the MVO2 or the mixed venous O2 is elevated, that indicates that there's a high cardiac output. And when the mixed venous O2 is low, that indicates that the cardiac output is low. Let me repeat it just one more time. quickly so you can get that stuck in your brain. When the mixed venous O2 is high, that indicates a high cardiac output because the blood is going through the body more quickly and it has less time at the tissue level to exchange gases. So when it goes back to the train station to get refilled again, it already has more oxygen in it because it didn't have time to drop off all the oxygen at the tissues. Conversely, when the oxygen level, the mixed venous oxygen level is low, that's because the cardiac output is low. So the cardiac output is low. It takes longer for the blood to make the whole circuit around the body. And because it's low and slow, the tissue gets to pull more oxygen off of the molecules, off of the hemoglobin molecules. So when the blood gets back to the heart, there's less oxygen left because it spent more time at the tissue level because the cardiac output is low. All right? All right. So what's the nurse's role? What's the nurse's role in hemodynamic monitoring? Well, we get to help put in the device when you're a critical care nurse practitioner or acute care nurse practitioner. You can be the one putting in the lines, but as the RN, you'll be assisting with that. You'll set up the tubing and get the dressing all taken care of and take care of the line and maintain all that stuff. Your job is to also do what you can to prevent central line associated bloodstream infections, or CLABSI. You're also going to continuously monitor and report all the hemodynamic values and notice the waveforms and all that stuff. Collect all those values, document them in the chart, and then you'll follow through with orders to treat any of those hemodynamic abnormalities. So a couple of other things to keep in mind with the central venous catheter. Remember, it can be femoral or subclavian or jugular. We can do other things through this too. We can also put in a temporary pacemaker through one of these devices, through the introducer sheath. Or there is such a thing as a pacing swan, which they usually don't work very well. Better usually to have just a temporary pacemaker, but sometimes we are successful getting them to pace with a swan. And then that device hooks up to an external pacemaker that we can adjust and keep the patient in good shape that way. We can also infuse things through this. We can monitor, and we can also do dialysis through very big central venous catheters. Usually not the ones put in for the swan and all that, but rather bigger ones. So subclavian insertion is shown here on the left. The internal jugular is shown here on the right. Remember that we need to get a chest x-ray of all these patients after their line is put in. And then we're going to monitor and document all these things like the waveforms and the numbers that we get from it. You'll also need a central line bundle that will give you all the tools that you need to prevent infections. So there's these little discs that we put in here that are impregnated with antibiotic kind of things. And we have the green caps that we use, again, all according to the policies and procedures of the organization that you work at. So this is one other attempt I'm going to give you to explain how you set up these transducers. So again, remember that when we have the bag, it has to be put in a pressure bag with this pressure bag around it so that the pressure can overcome the arterial or the pulmonary artery or the CVP pressure so that we can get tracing. Now, the way the tracing works is that these transducers then are hooked up to this infusion, and it's pressurized infusion so that it pushes back against the pressure of the blood, either in the artery, pulmonary artery, or the vein. And then this device goes to the patient through the catheter or, through the catheter, whether it's a swan, like is shown here, or through the ART line shown here, it's transduced here, and the transducer is the thing that changes that pressure into an electric waveform that you can see on the monitor. The phlebostatic axis we talked about already, fourth intercostal space, mid-clavicular line. That is the level of the left atrium. But remember that that's only useful for a pulmonary artery catheter, right? If you have a radial artery that's that has a catheter in it, we're monitoring the radial artery pressure, then that device actually should not be monitored at the phlebostatic axis, but really that transducer should be at the tip of the catheter. And so the transducer for an art line really should be at the art line. But, we're going to allow some variability in that just so we can keep all the transducers together at the level of the phlebostatic axis. It's not the end of the world, but again, a purist like me would want to have this transducer at the tip of the catheter. And the tip of the catheter in a pulmonary artery is right here at the phlebostatic axis, but the tip of the catheter for an art line is at the art line. So this is the arterial waveform. Remember that the arterial waveform should have a dichrotic notch. The dichrotic notch is formed by closure of the aortic valve. All right. And so when we look at a good tracing on a art line, we're looking for that dichrotic notch. If you don't have a dichrotic notch, then it's either not an art line, or you may have some clot or something building up on the art line that's decreasing the fidelity of that tracing, and you should probably flush it to get the dichrotic notch back again. The CVP is usually a blue tracing, and that blue tracing has beside it CVP. And remember the things that we see on this. We see an A wave, a C wave, and a V wave. Remember those? The A wave, the C wave, and the V wave, those are what we see in the CVP tracing. A wave, C wave, V wave. That's how you know it's an art line. That's how you know it's a CVP tracing. And you can see the A wave, the C wave, and the V wave on this diagram. And they sort of match up here when you look at although there's no EKG, you can use the art line tracing as the equal to the EKG. So this is an art line that you see in this patient's wrist. It goes right into the radial artery here. This is the pressurized line that goes into the device. And then this is the stopcock here. This is a cap on the open to air part of the stopcock. And then this goes into the artery through this catheter here, and it's sewn in place. You'll see that, and you have to be careful with these that you don't rip that out, because this can cause quite a mess, obviously. The other important thing to know is that you do not put medications through this ever. This is for monitoring only. All right. We can also draw blood from it, which is really convenient. You don't have to puncture your patient. You just open the stopcock with a syringe on it, and it fills the syringe, and then you can put it into the tubes, or you can use the little tube filler device as well. But it's very convenient to have an art line to get blood from. Nursing care of the art line. So again, assist with the insertion, maintain the dressing and all that. You always want to check the pulses distally. Check the flow of and the tissue integrity distal to the arterial line. So you want to make sure that they have good circulation in the fingertips, essentially. Okay. And then what about a patient with a pulmonary artery catheter? Well, very similarly, we're going to monitor all those things. Typically, we do them every hour while the patient needs it, if they're in shock or right out of the operating room. And then later on, we go to Q4 hours as needed. We keep the position of the catheter correct. We don't ever want to let the pulmonary artery catheter float into the wedge position for more than a minute, because if it does, it can infarct the tissue downstream, right? So we have to be very careful about that. Just make sure that that device doesn't migrate too far. And we always keep track of how many centimeters in it is. We don't want it to go past 30 or 35 centimeters in most patients, because that's in too far. And again, we don't want to cause a problem with the pulmonary blood flow. There are complications that can happen. This is a pulmonary artery catheter that got a knot in it. You can see this knot. Well, when you get a knot in it, you can't get it out. And they actually had to go in and operate on this patient, open up his heart, and pull the catheter out. Had just a mess to do that, I can imagine. But this is one of the complications. I've actually never seen this complication. I think you would have to try pretty hard to put a knot in that thing, but it is a possibility. Infection for sure. Ventricular arrhythmias, as you poke around in the heart, particularly as you're floating it in through the right ventricle into the pulmonary artery, it can cause the heart to skip a beat or two. You can have thromboembolic events, but typically they go downstream, right? And it gets stuck in the lung and nobody ever knows it. We can have an air embolism from a ruptured balloon. Again, tiny air embolism wouldn't amount to much. But we do have to be careful about pulmonary infarction, again, by leaving that balloon open accidentally. Closed. Let me just rephrase that. Leaving the balloon inflated accidentally can lead to pulmonary infarction. So we definitely don't want that to happen. And then there is such a thing as a pulmonary artery rupture. I've seen it twice in my career. They are often associated with patients who have who are still cold when they're coming out of the operating room. It's usually a bad idea to try and get a wedge pressure on a patient until they've warmed up. Pulmonary artery ruptures are bad news. And the way you know that you have a pulmonary artery rupture is that you'll see blood in the endotracheal tube. And that's not a good sign. So this is one of the other complications of CVP insertion. Here you can see it went into the subclavian vein, and it came down here toward the right atrium. The right atrium's down here, but this is definitely in the central venous circulation. Here we see the tip of the catheter, or the endotracheal tube. This is the carina here, so it's 2 centimeters above the carina, which is about where you want it. But look over here. These black arrows are pointing to the lung, right? You look out here, you don't see any lung tissue markings like you do over here. See these little white markings that you see all the way to the edge? Well, here they stop right at this line that you see here, all right? And so this patient had a pneumothorax that was complicating the insertion of the device. So that's what I wanted to tell you about today. We talked an awful lot about some things that are potentially quite confusing. You may have to go back and listen a time or two. And I hope that you'll contact me if you have any questions. And hopefully you learned a lot from this little lesson today. Take care.